everyone, welcome to Cardiff. I'm Andrew Shah. I'm a consultant interventional cardiologist at the University Hospital Wales in Cardiff. I'm joined today by Sean Gallagher, our Director of Interventional Cardiology. Hello, Sean, how are you doing?
Very well, Andrew, thank you.
We're doing a left main case today, and it's one we've recorded previously and put into a box and edited. So we're going to talk through the case as we go. We're also going to give a little bit of background on how we use Ivus in the left main, what we're trying to achieve, as well as showing the video of the live case that we did that was very interesting. And you'll see the twist as we go along. So thank you for coming on a Thursday evening. Those are our conflicts of interest, which include both of us being a consultant to Philips. So we're going to talk about left main stem PCI. So this is a truism for anyone who does imaging. If we do imaging, we realize that when we see a lesion, either in the ostium of circumflex, the ostium of LAD, or in the distal left main, it tends not to be isolated to that. 90% of left main lesions extend into the LAD, and there are multiple different patterns of disease that can present. And we need to know this if we're going to be doing, say, a single stent crossover strategy, or we're considering a two-stent bifurcation strategy. And what are we trying to achieve when we do left main PCI? Well, this was reported by Kang about 11 years ago. And it's in an East Asian population, so it's not entirely representative to some populations, particularly in the Western world. Excel is probably more appropriate for that. But what Kang showed is that if you're doing bifurcation PCI of the left main, you need to try and achieve a minimum area at the ostium of circumflex of greater than 5 millimeters squared, at the ostium of LAD greater than 6, at the bifurcation so-called polygon of confluence 7, and then in the left main 8. Now those are pretty conservative targets, and we'd want to get bigger than that, particularly in the left main and in the LAD. Sometimes we accept an area in the ostium of circumflex of 6 or so. But those are minimum targets, and those are the ones we're using in the optimal study of Ivus-guided left main PCI. 5, 6, 7, 8, nice and easy to remember. And what did it show? It showed about an 8% difference in events for the group that achieved that versus those who didn't. But crucially, if you did achieve that, your event rate was tiny. It was only 1.9% out to 2 years, whereas it was 10% if you couldn't achieve that. So we're aiming to get big stents or big native vessel if you've only done a single crossover stent, 5, 6, 7, 8. This is another famous paper by Park from South Korea, published a long time ago, 2009, showing that it's not randomized, but in his lab, if you used Ivus for the left main, you achieved only a 5% event rate. If you didn't use Ivus, you had about a 15% event rate. So a big difference, and it was this is for mortality. So in Excel, the 3-year outcomes were dependent upon the area achieved in the left main. So if you're only able to achieve between 4 and 9, your primary endpoint rate was 19. If you were 9 to 11, it was 12. And if you were above 11, it was 11%. So we had substantial and graded reductions in event rates. The bigger you got your left main stent minimum area. So you can see 11 was what they aimed for. And they did an overall analysis using 9.8 as a cutoff. So let's call it 10. If the smallest bit of your left main stent was 10, your 10 or more, your event rate was 11%. And if it wasn't, it was 18%. So we've got a couple of cutoffs for our guidance. From Kang in an East Asian population, 5, 6, 7, 8. 5 in the circ, 6 in the LAD, 7 at the bifurcation, 8 in the left main. That's probably a bit conservative for a Western population. In Excel, we want to try and get the left main smallest bit of the stent above 10 millimeters squared cross-sectional area. So I hope that's clear. Okay, so we're going to get into the case now. That's enough of the lecturing. And we're going to talk through a case that Sean and I did. So Sean, tell us about the case. Give us a bit of background.
Thanks, Andrew. So just taking you through the case, we'll see the pictures in just a moment. So this was a case we recorded last year. And this was an 80-year-old patient who had had PCI in our institution about 10 years before he came in. and had done very well. His initial presentation was with stable angina, and all we knew is he had a stent in the LAD. We had no details of that, no stent sizing, no old angiograms. Not that unusual here at times. And he represents with a 6-month history of increasing angina, and there'd been attempts to try and settle him medically, which had failed. And it had an angiogram by a colleague of ours, which showed significant disease in the mid-right coronary artery and an ostial circumflex lesion. And it had PCI to that right coronary artery in isolation, but his angina continued. So he'd come back for PCI to the ostium of the circumflex. So if we can show those pictures.
Okay, so we're on to video now. Here we have some set of angiograms. Tell us what we're looking at, Sean.
Well, as you know, I take my own set, so I tend to start with an RAO, so we can't really see an awful lot, but I start with an RAO mainly from CTO because I like to be able to see the septals and plan where I'm going to do. So it's just become my thing, I suppose. What you can see now is you can see the stent in the proximal LAD. At the front end of the stent, the left main doesn't look quite normal. And you can see a severe ostial circumflex lesion in what is, you could argue about it being a left main trifurcation, or you could say it was a very early OM. So initially, well, I mean, what are your thoughts, Andrew? I mean, I had some concerns here with how we were going to deal with what was in essence a left main trifurcation, but certainly some thoughts about the distal left main into that LAD stent and what might be going on there, because we simply didn't know.
Yeah, so I've just run it around again. So we can see the old stents here that were almost 10 years old. We haven't shown the right. The right is fine. So we can see here that we have a critical lesion at the ostium of circumflex. And what's interesting is, although the stents are 8-9 years old, they look in not bad shape, Sean. What do you think?
No, I agree. He certainly likes stents. The LAD looks pretty good angiographically.
Okay, fantastic.
I think the strategy of treating the right coronary artery and having a think about the circumflex, I like. An ostial circumflex in isolation is my least favorite intervention, because there's often quite a lot of jeopardy in coming across the LAD for the circumflex. And if you're going to do it, I like to know that I'm doing it for the right reasons. So I like the idea of treating the right, seeing if he settles. He's in his 80s, and now bringing him back, knowing that he continues to have angina despite 3 anti-anginal agents.
Yeah, and it looked like we weren't going to have that much difficulty in wiring it, but it turned out to be a little bit more difficult than we expected, which actually was a clue to what was going on, but we didn't quite realize at the time. So we don't have the wiring on camera because it took probably about 5-10 minutes. So tell us what happened when you tried to wire the circumflex.
Well, I couldn't. I thought it would be pretty straightforward to wire. And it wasn't. So I popped a wire down the LAD, no problem at all, and couldn't wire the circumflex with just a standard cyan blue coil tip wire. And I thought the easiest thing to do in my hands would just be exchange out for a microcatheter. And with this anatomy, I took an angled microcatheter and directed into the circumflex and then popped the cyan blue down. But as you say, it was probably telling us something at that point. Yeah. And once we'd popped the wire down, we were able to follow it relatively easily with a small balloon and just dilate the origin of the circumflex to get the Ivus probe down. Yeah, I mean, I remember thinking at the time, Sean's lost his touch here. This should be straightforward to get around. And I couldn't quite work out why you couldn't get around. And so we got into the circumflex here and we pre-dilated and we've got an eagle eye Ivus down. So this is the 20 megahertz device. And we're doing a co-registration here, which we haven't covered in the previous Ivus sessions that we've done. So what you do is you put a wire down, you do a manual pullback with the eagle eye device, and you do that under continuous fluoroscopy. Then that's what you see on the right-hand screen in the co-registration system. And then when you get back to the guiding catheter, you do a cine angiogram and it will synchronize the images on top of each other. So it will synchronize the angiogram and the Ivus. As we were doing the pullback though, we got a little bit of a surprise. So I will run it again. So it's running through here. So you can see that we're looking down at the very last minute and concentrating on the mechanics of the PCI. And it was only when it was running back through that I realized that there was something unusual about this Ivus.
So well done for those of you who spotted it. So we're now doing the cine angiogram. And so it's now going to automatically superimpose the Ivus run that we've done by manual pullback onto the angiogram. And then we can now click on the angiogram at any point and be able to see where that Ivus cross-section is on the angiogram. So you can see here, we're looking for a landing zone in our distal circumflex, see what it looks like. There's some eccentric plaque there. And then you can drag your cursor along the angiogram and it will measure it very precisely for length. So my arrow's in the way, but we're about to see the lengths that we're doing. And it's accurate to within about 1 millimeter. And it's able to do this because on the eagle eye catheter, there are 10 millimeter markers. And so the computer can work out the degree of foreshortening from what the distance is during the pullback, because it knows they must be 10 millimeters apart. And so if it shortens, it knows that there's foreshortening, and that defeats the problem of QCA, which can't deal with foreshortening. So as we're scrolling here, I'm looking and saying, where would a 38 millimeter stent land? And then suddenly this thing appears. And then we pause for a moment and go, hang on a minute. So I think I was looking down during the live pullback at my hands. And so I hadn't seen it on the first run. But there's a surprise there. So you can see from the co-registered angiogram where we are on my arrow. We're in the left main. And this is what we're looking at in the left main. So I'm sure you're all wondering quite what that is. So Sean, we didn't expect this at all. We from the angiogram, we could not see this appearance in the left main at all. We knew there was stenting in the LAD, but what have we got here?
Well, yeah, you're right, Andrew. But the angiogram really didn't tell us what was going on. As I was talking through the angiogram at the start, it looks a little bit odd in the distal left main, but the stent looks great. There's another clue that I don't think we picked up on the time, which was I was trying to bring my guide back as I was pulling back with the Ivus probe from the circumflex, because I didn't want my guide dragged into the circumflex ostium. And really, something was gripping the Ivus probe on that kind of flexion point into the circumflex. And we suddenly pop through what is the side struts of an old stent coming back from the LAD and straight back into the guide. So have we got that if we play it through? So what we're just seeing there is basically the stent from the left main protruding back into, stent from the LAD protruding back into the left main, and it's just floating in space.
Yeah, and that's been there for 8 years.
Yeah, absolutely.
And it does make me wonder. It was a very strange appearance of the ostium or circumflex. It was absolutely focal. I mean, yes, there was some disease, but it was so critical. And the fact that you couldn't get the wire across, we should have guessed there was something funny going on. And what had happened is with the help of the microcatheter, he had wired through the side of that stent, which turned out to be very helpful. So I think we've got a little bit more video here. So we've now got another wire down the LAD, and we're doing a co-registration of Ivus from LAD back to left main, and we're trying to work out a bit more of what's going on here. So here's the old LAD stent from 8 years ago, and it's actually not bad. I mean, considering it wasn't an Ivus guided PCI, we think, otherwise they would have seen that left main problem. We've got a 3 by 3.3 millimeter lumen. There's very little neo-intima. With the co-registration, you can very easily measure this. And then you can see how there's a yellow line dropped on the LAD there, on the co-registered angiogram, which will give us a landing zone if we wanted to stent. And then you can just drag back along. It'll give you very accurate measurements, and you can see precisely on the angiogram where the problem is. So this is the ostium of LAD. And this is how you really know that it wasn't an Ivus guided procedure, because look at the state on that. So we have a 2.9 by 3.4 stent in the ostium of LAD. Ordinarily, you can imagine how at the end of that angiogram guided PCI, the operators were quite pleased with it. Now, clearly there's a bit of positive remodeling, but we can see here that the LAD itself is 6 by 6. So we've got a 73% plaque burden relative to the stent. So it's a grossly underexpanded stent in the ostium of LAD, and it also hangs back into the left main. So not great. And again, this speaks to the importance of Ivus guidance when you deal with the proximal LAD. So what we've learned from the Ivus into circumflex is that we are between struts. We can work this out from the original Ivus run. We've got another wire down into the LAD that's within a grossly underexpanded stent in prox LAD, and within a stent that's hanging in the left main. And that distortion from that metalwork has probably created vortices into the ostium of circumflex that's created this critical stenosis. But we've got one stent this way. We've got a wire wired through the side into circumflex. So it's decision time, Sean. So we could have done this a number of ways, but tell us how you and I decided how to solve this problem.
Well, it says on the slide, it says that we decided to do a clot, but I'm not sure there's that much else we could have done with a stent that was hanging across from the LAD back into the left main with a wire through the side. The logical thing to do was a clot then. I think the more difficult decisions would have been, had we wired around the back of the stent? And would you crush an old stent into the LAD for the circumflex? How would you sort that out? That would be a much more difficult situation. And I think the state that the old stent was in, or rather what we didn't know about the old stent, we had no idea what stent technology that was, what platform that was. The fact that we were through the side struts into the circumflex was a little bit of a godsend. It gave us the opportunity to do a clot, so stem from the circumflex back into the left main, and then cross over back from left main into LAD and complete with kissing balloon post dilatation. It was the only logical thing to do from where we were. If you think about all other left main strategies, they were going to be pretty ugly from the position we were in, simply because there was metal left behind in the left main. Yeah,
I think if we'd have wired behind the left main portion of the stent into the circ, and then maybe we were pushing hard with our Ivus to get through, we may have deformed that segment. We may have chosen to crush it across, and then do a crush technique with the stent from the left main into circ, and then recross and kiss into LAD. But because we've fortuitously wired through probably the third cell of the left main stent, we're set up beautifully. We've done one half of a clot. The only thing is we did it 8 years ago. So we then move on. So we've wired through, taken a big balloon. And you sometimes see this, Sean, don't you, when you're going through the sides of old stents where the cell design is not designed to be able to expand up to the size of a big balloon. So is there anything we can do about that? We saw that there was a slight, almost napkin in the balloon at the ostium of circumflex. Anything we can do about that?
Not great. Not really. I think that stent is going to take what it's going to take. I think that was one of the points I made before. We don't know what that platform is, and we don't know what it will do. Also, I mean, it depends which strut you've gone through, where the connectors are in relation to that, how that particular strut is going to dilate. To be quite honest, yes, there's a little bit of a dink in the balloon as it's gone around, but generally, I think that's pretty good expansion at the ostium of the circumflex.
Yeah, it's not bad. So here we're through, and we've repeated the Ivus after we've done a dilatation with a 3.5 balloon, and we're looking for a landing zone. So we drop a landing zone where that white marker was, but it's 42 millimeters to the ostium of the left main, which we've decided is where we're going to land our stent. The problem is we don't have a 42 millimeter stent. So what we've done there is we've remeasured from the ostium of left main back down to 48 and chosen our landing zone. So I'll just show you that again. So we're looking here for a landing zone where we can, and we've dropped a white marker there. We think that's a good Ivus landing zone. We've dropped that on the angiogram. We can then scroll back to the ostium of left main and see how long the stent it would be, and it's 44. And the problem is we don't have a 44 millimeter stent. So what we do is we decide to look for a different landing zone. Are you able to put the attendees on mute? We're just hearing family conversations again. Sorry about that. And we go from the ostium of left main to a 48 millimeter distance where we do have a stent that long. And we reassess our landing zone and find it's beautiful, it's nice, it'll take a stent nicely. So here we are in the iliocranial. So we're looking to make sure our stent is truly at the ostium without being too far out. You see the nice image stabilization technology on the co-registration system from Philips, where it stabilizes the stent inflation so you can get a good look at the balloon. here it is in an areocaudal projection down in the left-hand side. And so we're looking not too bad at the moment. So we've got the stent that's, I think it was 3.5, that goes back to the ostium of left main. And now it's time to pot.
I think that's an important point though, Andrew, that knowing your stent platforms when you're stenting from circ or LAD back into left main, and what size stent you're going to take and what you're going to be able to post dilate it up to. So I think this was a 3.5, which means we're safely going to be able to go up to, with most stent technologies, somewhere between 5.5 and 5.8. So we should be able to oppose in the left main.
Yes. So I think the 3mm platform will go to about 4.75, and depending on which technology, but a 3.5 will typically go a little bit higher to 5.2. So I think that's why we pushed the landing zone a little, which had measured 3.3. We went for 3.5, and then that allowed us to post dilate up to 5 point something in the left main.
And an interesting point in the left main, though, Andrew. Do you think you have to come back to the ostium?
No, I don't think we have. No, and I think in Excel there was an appreciable amount of longitudinal stent injury. I think it was over 5%, whereby the operators had damaged the ostium of the stent without realizing, and it was captured on Ivus at the end. And so I personally try and land it, if it's a healthy true ostium, about 1 millimeter in. How about you?
No,
Do you always go near the ostium or at the true ostium? Or
I think if you've got a healthy left main, a healthy shaft of the left main, I do exactly the same thing. I go near the ostium, but I don't hang it out.
Yeah.
But if I've got disease back to the os, obviously, then I treat it like an osteal lesion and I come back in. Well, the first thing I do, which I'm not sure all operators do, so for left main, I'm 100% Ivus use, so I will know the size of my left main when I deploy the stent. And the first thing I have in my hand after I've deployed the stent is a post-dilatation balloon for the same size of the left main, so that I've optimized the inlet of the stent as the first thing that I do. The hardest situation you get into, I think, in left main PCI is losing wire position with a stent that's not been optimized in the shaft of the left main, because getting back through the stent can often be a nightmare. And the other worry is damaging the front end of the stent with the guide. So if you pot as the first thing you do, you can take those potential catastrophes out off the table early on.
That's right. So if I just give you a little example here, it's slightly exaggerated, but if we've got the stent floating in the middle of the left main and we lose our wire, we may go either side of the pen. So we get the pen expanded up onto the wall, so that if the wire comes out or we rewire, we make sure that we go through the stent, not behind the stent, because that's how we're going to damage it. Okay, great. So we've now got the Ivus back down again, and we're just having a look at our results. So I'll just play this. So what are we looking for? We're looking for the exit of the stent. So I'm gradually scrolling back until we see the exit point of the stent. It's a nice, healthy vessel at this point. There's the stent stroke coming in at 12 o'clock. And we're rolling back and forwards to make sure we've got no dissection. There's a little under expansion there. You see the stent was off the wall. And I'm now about to measure the stent result and see how big it is. And it's a little on the small side. We wanted 3.5 diameter at that point, and it was more like 2.7. We scroll back to the ostium of circ, and we're slightly worried, will it have expanded properly? And in fact, it's done it nicely. There's a guide catheter in there. And that's sometimes what happens with the eagle eye. As we pull it back, sometimes it pulls the guide in. So it just needs counter traction on the guide. But we're now at the ostium of circumflex. And remember, we're aiming for more than 5 millimeters squared at the ostium of circumflex, according to Kang's formula from his left main study in Southeast Asia. And here I've been a little bit rough and ready with the measurements. But here at the ostium of circumflex, we've got a slightly elliptical opening, but that's okay. It doesn't matter. It's the area that is the key. And we've got an area of 14.5. So we're pretty pleased at this point, Sean, right? And this is where the critical lesion was. And you can see up in the left corner of this image that the dropout up in the left corner, that's the LAD coming in. So we know we're at the ostium of circumflex. We know we're coming into the polygonal confluence, and we're at the right place, the bifurcation, to assess the success of our PCI of the worst bit of the vessel. So that's looking pretty good. So we've had a pot with a 5 millimeter balloon in the left main. So what next? So tell us about how we would go from here.
Well, So the first thing I'm going to do in this situation, I'm going to optimize that stent. So I'm going to work on the circumflex stent first. I'm going to want a 3.5 NC balloon into the distal edge, optimize it all the way through, optimize the ostium pot in the left main, as we've said. So we're not doing badly. And then it's cross with a wire into the LAD. And then we've got to decide what we're going to do with that old LAD stent. And we've essentially set up for a calotte. So the first thing I'm going to do with the calotte is I'm going to take a small balloon from the left main into the LAD, make a hole, and then we're going to optimize that stent as best we can. We've already Ivus the LAD, so we know what we're trying to achieve in the LAD. Now, it's a little bit difficult at the ostium of the LAD because we've got so much positive remodeling. I don't think either one of us believed that the proximal LAD was 6. So I think you have to be a little bit pragmatic. You've also got to say that an 8-year-old stent looks fantastic, even though it was undersized. So I think we just took a slightly pragmatic view of optimizing it to a reasonable size, even though it probably wasn't the size of the positively remodeled vessel. So we were going to optimize that LAD stent with an NC balloon and a drug-eluting balloon to get the best result we could, and then complete the KISS.
Yeah, I think that's an important point is when people are new to Ivus, they sometimes come across positive remodeling in the Prox LAD and think, my goodness, we need to take a 5.5 balloon. And we've just got to be a little bit cautious about this. So the left main was about 5.3. So it's unlikely that the LAD was 6 when it began its life. Just 10 millimeters into the LAD, we measure the diameter of the LAD at 4. So if we take a balloon size just on that slice at the ostium of LAD, where the media to media diameter is 6 millimeters, we could potentially rupture either the distal left main upstream or the LAD downstream. It's 5.5-ish upstream in the left main, it's 4 downstream in the LAD. So when you're doing Ivus, and this is one of the nice things about co-registration, you can very easily scroll up and down, work out where you're going to balloon from and to, and just have a check that you're not sizing on an inappropriate segment. And you want to be sizing for the distal edge of the balloon. If the distal edge of the balloon is a 4 millimeter diameter segment, don't go above 4. What we've recrossed with a wire into the LED, we've taken a small balloon through, we're ready to optimize it and then do a drug-eluting balloon and then a kissing inflation. Do you want to talk through from here, Sean?
Sorry, I was just talking through the wiring of the LED. It was pretty straightforward because we've got a big modern stent coming from the circ into the left main with big open stent struts. So we got the wire down very easily, balloon through, and here we've got the Ivus. Now we've seen a lot of this already before, that the LAD stent looks pretty good, certainly distally. And as you come proximally, it's a little undersized. I'm about here as we were coming back past. You're just popping backwards and forwards through the mid vessel. So it could do with a little bit of a squeeze in the proximal portion of the stent.
Yeah.
But generally not too bad, the LED stent.
Yeah.
But
surprisingly so.
Absolutely.
But here we're starting to see a significantly undersized stent. So the blue one is the size of the stent, and it's 3 by 3.3 in the ostium of LAD in what was a 4.5 probably vessel when it was born, and it's now grown towards 6. Okay, but
I think that's an important point, though, Andrew. I think the more Ivus we do, the more we're starting to understand about vessel sizing. Yeah. That I think classical teaching of angioplasty, certainly when I was training, I was taught that proximal LADs were 3.5 millimeters in men and 3 in women. And that's what we should be aiming for, and maybe a 3.5 millimeter stent in the right coronary artery. Now with my practice, and I'm Ivus, well, probably 80% of what I do, including STEMI, you start realizing that we were wildly wrong. I mean, most men's proximal LADs are 4 to 4.5 millimeters. Women are probably 4. Right coronary arteries are normally 4. And we've just been undersizing stents for years.
Yeah. I mean, what's impossible to predict is where the LAD tapers down. So there's a very good study on this, in that you ask operators how big is the LAD, and you show them then a cross-section near the ostium of LAD, and they're always surprised by how big it is. But the septal branches come off at such a rate that we always underestimate the tapering. And so there was a study that showed that it was, the correlation was under 0.5 for could you predict the diameter between the first septal and the mid-diagonal. And it was almost impossible to guess what the media-to-media diameter was accurately and consistently, because we can't appreciate the amount of septals coming off, because some of them are even below the resolution of angiography. But it gradually tapers the LAD from that first septal point onwards.
So if you can't guess, should you measure?
Well, that's it, isn't it? This is why you should always use Ivus and the proximal LAD. And this is why co-registration is lovely, because actually it's quite difficult to size graded balloons for that segment from the first septal down to the second diagonal, because you might need 2 or 3 different sizes if you really want to get good smoothed apposition. There was a stent called the Morpheus stent that was designed to sort of grade it. It never caught on. It was a tapered expansion of a stent to try and map that tapering of the LAD, but that never caught on. So we have to do it ourselves with pulse dilatation. And without doing serial measurements and gradings of balloons along that length, you're going to have either malapposition or under expansion, or you're going to risk taking a balloon that's too big at certain points and risking rupturing, which is why the most common place to rupture any vessel is the knuckle of the LAD as it turns down to go towards where it would be intramyocardial. So if you picture the areocaudal view, the LAD goes out like this, and then it turns down and goes down like that. That is the point of the highest rupture risk of non-CTO PCI. And it's because it's within that tapering zone, and it's on an angulation, and the distal edge may be going down intramyocardially, so you've got a hinge point. So if we haven't said it enough, Ivus your LADs, because you can't guess. But interestingly, this old stent, whatever it was, 2008, so maybe it was a cipher, had surprisingly little neo-intima, actually alarmingly so. I always like a little bit of neo-intima to cover the stress. Okay, so then we were on to our final steps. So 4mm drug-eluting balloon in the LAD, and then kissing with a 3.5 in the LAD and 4 in the circ. So we've undersized a bit. So Sean, I've often wondered this since I was a fellow. We've got a 5.5mm left main. Maybe we could push towards a 6. But we've got a 4mm balloon in one arm and a 3.5 in the other. That's 7.5. Why doesn't kissing rupture the left main more often?
Well, because the vessels kind of mold together. I mean, they don't make up their combined diameters. There is a formula for working it out, isn't there, of what they come out at? I can't tell you what it is off the top of my head. But the way I do these procedures, and as I was operating, so I tend to optimize both limbs of a bifurcation independently. So I will optimize with NC balloons to circumflex first, back into the left main and pot the left main. I'll then optimize the LAD back into the left main. And then at that point, all I'm doing is it's a relatively low pressure kissing balloon optimization with semi-compliant balloons. And all I'm trying to do at that point is just reshape the carina, because I have fully optimized the stents as best I can independently with NC balloons. And then I do a final pot to get rid of any kind of elliptical left main from the two kissing balloons extending back. But yeah, to answer your question, it's because the balloons conform in the left main and they don't end up as being they don't end up as being the two diameters.
Yeah, and we're also doing a low pressure inflation. So I've seen people do kissing inflations in the left main at 14 atmospheres with 2 NCs. And I think that does risk a rupture at the bifurcation point of the left main. So just to emphasize, there's loads of ways to do this. And the guidance says, I think, to non-compliance, but it's not based on strong data, to my understanding, is high pressure inflation in the LAD to left main, high pressure inflation left main to circumflex. So we're doing one branch each, and then pot, because we want to make sure it's nice and round. Then a low pressure inflation in both branches simultaneously with the kissing inflation, because we're not trying to expand the stents. We're just trying to turn them from an oval like that into a circle like that. And then we're potting at the end. So, it's a little complicated, but it's the left main, right? I mean, and I remember Tom Johnson from Bristol was talking on a panel at the British Angioplasty Society a few years ago, and there was a big discussion saying, Do you have to pot the left main every time? Do you have to pot after every kiss? And his point is quite memorable. It's like, if you have imaging, then just look. So if you've decided that the stent is protruding out of the ostium of left main, and you're a bit worried about taking all these balloons in and out in case you catch the ostium of left main, just have a look with your imaging device. And if you've got a perfectly round, fully expanded stent, you don't need to take any more balloons there. If you once you've done your kiss. In the end, imaging gives you advantages that prevent you from making unnecessary steps and unnecessary mistakes. And then we did a 5.5 in the left main. And then just because we had that area of positive remodeled stent, we just took a short 5 and just went up at relatively low pressure just to try and get the most out of the ostium of LAD. So we're coming to our final images here. And we're just going to show you how we did the LAD. So you can see at this point where the yellow marker is there, that's what we're measuring at the moment. It was 5. As we're coming back towards the left main before we've fully dilated and kissed, you can see how small the ostium of left main back into LAD is, left main is. This is the ostium of LAD. Do you see the circumflex up there? I'm just flagging it up now. And we're seeing how before we've done our drug-eluting balloon in the LAD, before we've done our optimization of the old LAD stent, how grossly underexpanded that stent was. And amazingly, it had got through 8 years without an event, although it's almost certainly triggered the circumflex problem. And then we come back into the left main and we're not perfect by any stretch. So we're 3.8 by 4.1, so it needs more work. So this is several steps back before the slide I've just shown. Again, we're in the left main. Left main is huge at this point, but again, we want to be careful. So here's our pot and our LAD stent optimization. And then we're going to...
Andrew, I think it's probably worth just stopping just at that balloon. I mean, if you remember, we knew that we had the positive remodeling at the ostium of the LAD, so we could let our pot balloon just run on a little bit. So that's a big balloon going across into the LAD. But that is also a balloon after a case that I've done that scares me, in that with these very big pot balloons, often the beyond the marker, there's still quite a lot of balloon. Yeah. And if you leave that in the LAD, there is a potential risk for rupture in the LAD. So I tend to try and keep these balloons back away from the true or the ostium of the LAD and sort all of that out with kissing balloons. But in this particular case, because of the positive remodeling, we were comfortable letting the balloon just sit on a little bit. So a little bit more distal than I would normally want it.
And again, it's understanding what we're dealing with, that we've got about 8 to 10 millimeters of 5 to 6 millimeter LAD from the ostium. So it allows us just to make sure that we get right across those struts and safely go bigger than we normally would just on the basis of angio guidance. We'd never take a 5.5 into the ostium of this LAD without knowing what we're dealing with. I'll just carry on with the video. So at the moment, we've crossed through the side of the left main stent into the circumflex. We've parted it. We've stented to complete the clot. We then recrossed and opened the struts and potted with a big balloon. And we're setting ourselves up now to optimize the LAD stent with drug-eluting balloon, which I think is this step here. And then we subsequently kiss and pot to finish. So I hope that's all clear. So this looks like there's another balloon coming in, getting ready for our kissing inflations. And try and store everything under fluoro if you can. If you're doing these long cases, keep the radiation dose down. Here we go. So we haven't shown you the LAD drug-eluting balloon here, but that was done as a separate step. And then there's our kissing inflation. We're not going mad. And then we have a look with the Ivus. So the final run on the Ivus, it is a little small there. Do you see there's some malapposition at 5 o'clock? Do you see how thick the stent strut appears and how it's off the wall? So we come back and we fix that. And then as we scroll back, we're into the left main, starting to look a bit better. Stents are all nicely on the wall. As we come back towards the distal left main, Again, it's a touch on the small side, and we'll need to fix that, and we do. We take another balloon and optimize that. But what's interesting is even with a 5.5 balloon, we've only got the stent to go up to 3.5. So if you can imagine that you've done a good job, and you think, well, I've got that big fat balloon in at the end, I don't need to do anything else. But actually, we showed that it was underexpanded and needed another go. And I think if you're doing that big pot at the end, look for the bigger of the two vessels that run off, so you can get a big balloon to optimize your left main portion. So here we look at the LAD again, and the LAD looks pretty good actually. And again, you see this distal left main is not right. If I can pause it at the right point. This is the ostium of LAD. I'm pointing towards the circ there on the co-registration. I'm just checking the true ostium of LAD, which is not bad. There's the wire going into the circumflex branch that I've just pointed out. And the ostium of LAD is not perfect. See, it's hanging off again. So we've ballooned with a 5 or 5.5 millimeter balloon from left main into LAD, and the distal left main isn't right, and the ostium of LAD isn't right. So just assuming that you look at it with Ivus and you think you've sorted it out, and therefore you don't need to go back and do a final Ivus run. We showed there that wasn't the case. So we went back, re-optimized with bigger balloons, checked again, and then we're on to our final results, which look pretty good. I think it would have been very easy to just wire into that circumflex, ram balloons through, do a single crossover stent, maybe even kiss, and leave an absolute car crash in the LAD. So how anyone could have done this case without Ivus, I don't know. So Sean, any final comments on the final results? I'll just play that again, just so we see those final results.
Well, I think, well, we both know that angiographically and with Ivus, we got a fantastic result. I think the first thing to say is that for years, we've seen live cases where people have gone fantastic angiographic result. Well, we knew that. We thought the LAD was a good angiographic result when actually the stent's all over. The stent is undersized and the stent's hanging back in the left main. And then we used to, the other line that people used to use is, well, he was fine. And follow-up was fine. Well, yeah, he was fine for a period of time, and then he comes back 8 years later and it's much more difficult to sort out. Actually, what we know now is we've got the best possible result from the situation we were in. If I'm being honest, I wouldn't have wanted to start the procedure from there. I wouldn't have wanted a stent hanging across into the left main, but with that anatomy and with a stent that was old and undersized, and with the remodeling of the LAD, I think we did a pretty good job with that. We were never going to achieve perfection, but we have achieved big stents, which are opposed, which are expanded, and cover pretty much all of the disease. I think our bifurcation technique was solid. I think we've optimized it as well as we can. I think we've given him the best chance of a durable outcome. And I think that's the key to Ivus. It's about, stents will still fail down the line. I mean, even when if we look at ultimate, stents failed at what, 1.5%, 2% 1 year, they still will fail. But at least you know you've done the best you can. If you haven't used Ivus, there is more you can do.
Well, these are our final results for the various components of the bifurcation. So this is the Kang diagram on the right that is being used in the optimal randomized trial of Ivus guidance in the left main versus angio guidance. So we're looking for 5 in the ostium of circ. Well, we got 16. 6 in the ostium of LAD, we got 10, and 8 in the left main, we got 17. The Excel cutoff as a binary number was 9.8. And then, but if you got above 11, your event rate was very low. So we've more than achieved that here. And so we're hopeful of a durable result. And just to follow up on your comment about, well, he did okay. Well, he did okay. But if you do 10 cases like this, I'm not sure all 10 would do okay for 8 years. So
I would also say, Andrew, that if you just crossed over circ to left main and left a load of crushed metal around, what's his stent thrombosis risk then?
Yes, very high. We use co-registration here to great effect. We were able to precisely identify where the Ivus image was with respect to the distal left main, with respect to prox LAD landmarks, in terms of sizing our balloons to make sure we were not too large a diameter of balloon in the LAD wasn't extending too far. We were able to look for landing zones. So you remember we were thinking about taking a landing zone that would have been 44 millimeters back to the ostium of left main. And so we didn't have a stent that long. So we redid the length from ostium of left main to circumflex. We checked where the stent would land if we took a 48. We found it was actually a nice landing zone. So we were confident we could take a 3.5 by 48 from a new landing zone that we selected back to just about the ostium of left main. We didn't take it out of the left main to avoid the risk of guide catheter crushing. We'd confirmed on Ivus that we were through the side of the hanging left main stent rather than behind it. We also checked that the old stent was okay and we weren't leaving him with a future problem in the old left LAD stent. I think it was probably a cipher. There was so little neointimal perforation. We've checked how big the proximal LAD is, and we've shown it is so big that we can afford with our pot to just hang the balloon a bit into the LAD, which is helpful for making sure we get the distal end of the left main. Sometimes you can't do that. If you take a big 5.5 in the left main and you hang it out into the LAD, you're risking rupture at the bifurcation of the proximal LAD. Here we saw that there was positive remodeling at the prox LAD, so we were okay. As long as your balloon is below the media to media diameter of the artery at any given point, you're very unlikely to rupture. And then we've done what we think is everything we need to do. We've done kissing with good sized balloons, we've done pot, and then we went back for what we think is our final run. And we found that there's some malapposition in the circumflex. The distal left main isn't fully up despite a 5.5 balloon. And so we went back with higher pressure balloons at the distal end of the left main, sorted that out, re-kiss, re-pot, and then we've ended up with a very nice angiographic result. And this was about a year ago. He's doing fine now, Sean, is that right?
Yeah, no, he's doing fine. But he did fine for 8 years before. So I'm not taking any solace from that.
Yeah, exactly. We've got to get him to 9 years now. We've got to get him to 89 so we can say we did a better job. We've seen now in numerous large data sets the impact of Ivus guidance on left main outcomes. In Noble, which was a randomized trial of left main PCI, it was only used in 50% of cases up front and 80% of cases at the end. Those numbers were extraordinarily low in my view. In Excel, it was underused. In FAME3, it was grossly underused. It was only about 12% of Ivus use in 3 vessel disease. So there's very little excuse now. I've just completed a cost effectiveness analysis of intravascular ultrasound in acute coronary syndromes, and the paper is submitted for publication. It'll be coming out soon, focusing on the ACS group. And really, there's not going to be any cost argument. Once that comes out, it meets the international standard for cost effectiveness for a medical device, and that's with a journal at the moment. So hopefully, will be published soon. So the cost argument isn't there. It's safer. It picks up rare aberrances like we've just seen. It gives you bigger stents without increasing the risk of rupture. And it doesn't add that much more time to the case. I mean, we did that original case, Sean, in about 80 minutes. Is that right? Can you remember?
Something about that. I mean, yeah. I mean, I think Ivus makes you quicker because you start, you understand the problems. You deal with the problems sequentially. You don't hit these issues of not understanding why devices won't cross, because you understand right from the start. You understand what you're dealing with from the Ivus, and then you change your strategy depending upon what you're dealing with. So yeah, I don't buy the arguments of cost, that I think good healthcare is expensive, but bad healthcare is even more expensive. Dealing with failed stents is much more expensive than the cost of an Ivus. I also don't buy the argument of it slows you down. It speeds you up, if anything.
Well, I think when we're doing Ivus at our levels, it doesn't slow us down, and that's the key. Is because there's an expectation we're going to use Ivus. The only question from the team is which one do you want set up. So if we're going into a case with an expectation of Ivus, then everything's programmed into the system. The equipment's ready. It's all there. And as you say, there's no guessing. There's no taking a 3 and then realizing you have to take a 3.5 balloon. There's no taking a 3.5 then realizing actually you shouldn't have taken the 3.5. You've ruptured the vessel. You're spending an hour and a half trying to save the day, and so on and so on. Thank you very much for coming along. Keep your eye on my Twitter feed, which is at Dr. Andrew Sharp. So thanks, Sean. Thanks for Phillips. Thanks for OneView for organizing the session. And thanks everyone for coming.